Am I on? Can y'all hear me? Is that a yes? Okay. All right, here are my objectives. They're in the handout. This is my disclosures. I own a very small amount of stock in these biotech companies. But my primary disclosure is that I am not an expert. And I believe that really none of us are experts because we are continually coming to these type of meetings in order to grow and to better ourselves. One thing that's changed in my thinking is that I've moved from thinking about not only how I can be better, but how we can be better, how we as a group can do better. And this thinking is primarily influenced by the writer Atul Gawande. And if you're not familiar with Atul Gawande, I encourage you to go to his website, gawande.com, and read some of his New Yorker articles. He has several books that have been published. And he is a kind of a foundational and inspiring thinker and writer about healthcare and medicine, and he kind of thinks big. In this article, published a couple years ago, he looked at the restaurant chain, the Cheesecake Factory, and he wondered how do they achieve such high levels of quality, consistency, while maintaining affordability and keeping it consistent across the United States at scale. And he wondered, could healthcare, could medicine, big medical systems achieve those same type results? His conclusions were maybe. We'll see. But after reading this, I started thinking about how can we do this in our system. And so if you get nothing out of my talk but the name of Atul Gawande, then I will have done some good. Anyway, some background. I've been doing wound care since about 2006, both inpatient and outpatient wound care, caring for people with diabetic foot infections and diabetic foot wounds. And over that time, what I've seen is that the inpatient management of these patients is really fragmented and inconsistent. It can vary greatly among different providers. And that really stands in contradistinction to the fact that there's probably one of several best ways, quote, best ways to care for these patients that should work in the great majority of cases. And our goal is really to identify best ways that can work in about 90 to 95% of situations. So I believe that these best ways can be discussed, debated, and decided on in system-based committees. And at that level, we can develop protocols and order sets with subsequent meetings that can then refine and alter these protocols based on objective results. I believe these best ways help the system. It allows for rapid dissemination of change throughout the system as updates become available. And it allows care to remain more or less consistent as providers come and go. This should result, and has been demonstrated to result, in both improved outcomes and cost savings. These best ways help the provider, this being the kind of the bedside day-to-day provider, in that it eliminates guesswork, especially in areas where the provider might not do this kind of work all the time. Provides support, and it increases efficiency. And these best ways do help the patient in that outcomes are improved. So if you're looking for best ways about how to treat diabetic foot infections, this 2012 IDSA clinical practice guideline is a good place to start. This is what I found when I was searching around for some foundational knowledge. This is a very good resource. It is evidence-based, it's well written, it's easy to read and easy to refer to, and this really formed the basis, this and a few other articles really formed the basis of our thought going forward. So if you look at how care of patients with diabetic foot infections and diabetic foot wounds is delivered, you'll find that there's a lot of areas that lack standardization. And you're going to hear me say the phrase lack standardization and great variability several times in the next several slides. Starting out, if you look at the definitions, even the definitions are not standard. And our words, the words we use to describe patients mean different things to different people. So one person's severe infection is another person's mild infection. One person's infection is another person's colonization. One person's extensive foot infection is someone else's, it's just what I say every day. And so there's really not a standardized terminology for us to communicate what the disease is to each other. Certainly if you look at medical care, it's done in a variety of different ways as far as how long patients stay in the hospital, how glycemic control is done, discharge planning and criteria is all done very differently, kind of across the board. If you look at surgical care between surgeons, or even if I look at the way I deliver care myself, there certainly is some care variety from surgeon to surgeon and patient to patient. That being when to debride, when to amputate, how much tissue to remove, how to obtain culture data, and whether that patient is followed up as in an outpatient clinic or an outpatient wound care. Again, it's just all done very differently from provider to provider. Even when I looked at myself and how I do things, I would change things based on mood. And so if you look at imaging, again, what people are ordering to work up patients with diabetic foot infections, it just varies greatly kind of across the board. And different people order different tests. Bone scans, x-rays, MRIs have all been ordered in order to evaluate these patients looking for osteomyelitis or deep abscess. And it's like, working as a consultant, I work with a variety of primary care physicians and hospitalists, and just some people order bone scans, some people order x-rays, some people order MRIs, and it just kind of varies across the board. My personal bias is that MRI is likely very overutilized, especially in patients who come in with acute infections who need debridement that day. It's also overutilized in patients who you can look at them and examine them and clearly see there's no infection. And so I think there's an area that can be improved upon there, kind of appropriate utilization of advanced imaging technology, especially MRI. Next, we're going to talk about vascular evaluation. And again, the vascular evaluation is part of the evaluation of patients with diabetic foot ulcers and infection. Some studies have shown between 25 and 50% of patients who come in with diabetic foot ulcers or infection have some underlying arterial disease. And the definition we're shooting for here is the, quote, likely adequate perfusion for healing definition. Meaning we can, if they meet that definition, you can go forward in hopes that the patient's going to heal. But if you decide that adequate perfusion is likely not there, then you really can't go forward until you've gotten a vascular surgeon or an interventionalist involved. So what we find here is that some patients are getting an extensive evaluation when they don't need it, and some patients are not getting an evaluation at all. There's been a lot of studies on this. Here's two of them. The first one that I got quoted there showed that in patients with severe leg ischemia, only 56% of those patients receive some sort of vascular imaging prior to surgery. And the next one shows that if you're looking at patients who've received a major amputation, only around 50% of those patients had any kind of vascular evaluation at all. And so there's definitely an area, an opportunity for improvement if we can make sure that all patients who are being considered for major amputation undergo a vascular evaluation before that. But the other area that can be improved upon is patients who have palpable pulses and clearly have enough blood flow for healing just based on a bedside exam. They don't need an angiogram. They don't need a CTA or an MRA. You can stop and preserve those resources. Other areas where it's just kind of all over the place, antibiotics. There is a wide variation in initial selection of antibiotics. This is really not the practicing physician's fault exactly, because if you look at the IDSA guidelines, they give you about 10 different choices you can choose from. And a lot of it's just based on how people were trained and what happens to be used at that institution. At our institution, everybody uses vancomycin and zosyn. It's like a knee-jerk, vancomycin. But obviously that changes. That's different in different places. The literature doesn't really give us a lot of support here. There's really not a lot of data to support one regimen over another one, and so you just get everything. Again, there's not a lot of data to support a certain length of treatment. There's not a lot of data to support when to change from IV to oral, or when to stop antibiotics. And even these IDSA guidelines admit that. And there's been some subsequent publications to those guidelines that have shown that a lot of the recommendations are based on no data. It's just based on how I think it should be done. But again, this is why you can have, a system-wide committee can then recognize that, put forth something, and have everybody do it more or less the same. And then as data becomes available, or as research is done within that system, it can then be tailored. HBO, hyperbaric oxygen therapy, as an adjunct to diabetic foot infection and ulcer treatment. Again, the indications here and the benefit are really not widely known. HBO is certainly used in areas and centers that have HBO, but it's probably likely underutilized. And HBO for diabetic foot ulcer is really a whole separate talk, but I'm mentioning it there just for kind of completeness. So there have been studies on this, and this is a quote from a study from Europe from 2008. I guess I'll just read it. Treatment of many patients is not in line with current guidelines, and there are large differences between countries and centers. Our data suggests that current guidelines are too general, and that healthcare organizational barriers and personal beliefs result in underuse of recommended therapies. Actions should be undertaken to overcome these barriers and to guarantee the delivery of optimal care for the many individuals with diabetic foot disease. So the idea being that there are best practices, there are guidelines, the guidelines are evidence-based, but in these loose affiliations of physicians in certain areas, they're just not being followed or applied consistently, and the outcome from that is, the result of that is poor or less than optimal outcomes. So what to do? What we did is we created this diabetic foot task force. This in 2014. Really did these four things. We created a literature library of best practices. Primarily that was the IDSA guidelines and a couple of other broad evidence-based publications. And those became our foundational documents. We then used those documents to create a history and physical template and order sets to reflect best practices. Let me get some water. I'm sorry. Excuse me. We then developed the lower extremity assessment pack, which is an aid to physical exam, which I'll describe more in a little bit. And then we talked about methods to track outcomes, mainly identifying patients based on ICD-9, now 10 codes. And then out of those identified patient populations, tracking our length of stay, readmission, amputation rate, and how often patients received a vascular procedure. And then tracking the use of the template. How often are patients coming in with this diagnosis, and is the practitioner using the tools provided? The idea being to track that over time and then identify areas that can be improved upon and improve them. The Diabetic Foot Task Force was comprised of really all the different specialties that care for patients with diabetic foot infections, listed there. Surgery, ID, medicine doctors, ancillary staff. The first thing we talked about was a definition of a diabetic foot infection, and we used this IDSA kind of classification system in which patients who come in with a wound but no evidence of infection have no infection. In order to define an infection in a diabetic foot wound, you need at least two of those findings, meaning swelling, erythema, pain, drainage, warmth, kind of classical stuff everybody knows as far as when a wound is infected. An infected wound can then be divided into mild and moderate infection based on the depth and extent of the wound, and then an infection is termed severe if there is sepsis. kind of systemic inflammatory response to the infection. You can kind of look there. It talks. I can't really do it. Anyway, it's listed there, and this was kind of our first step. Let's talk about what is an infection. How do we define it? Part of the evaluation of patients with a diabetic foot ulcer includes a physical exam, and these are the tools needed to do a physical exam. And it's both a vascular exam as well as a kind of an ulcer exam. And we made little boxes, and in those boxes there's a Doppler, a blood pressure cuff, a little monofilament for doing sensory testing, a cutting curette, a ruler, a flashlight, and a Q-tip. And these little boxes are at the nurse's station, so a physician can walk up to the nurse station and say, "Give me the L.E.A.P box," and they hand you the L.E.A.P box, and you take it to the patient's room. Part of the evaluation is a neuropathy exam. What you're looking for here is loss of protected sensation. I recognize this is really more of an outpatient thing, and most of the patients that come into the hospital with a diabetic foot infection, they already have a diagnosis of neuropathy. They will tell you, "I have neuropathy," and you can just check the box. But the little monofilaments are there in order to complete the sensory exam if needed. And again, what you're trying to do with this part of the exam is just document the loss of protected sensation, which, as y'all know, is really the pathophysiology of a neuropathic diabetic foot ulcer. The ulcer exam is probably, this and the vascular exam are really the key components of the physical exam. Part of the ulcer exam is to document, obviously, the location, the size, the depth of the ulcer, the absence or presence of gangrene, and then whether there are any deep structures involved. The curetting the wound is part of the physical exam. The curette has to be used to remove the surrounding callus, scrape away some of that thick yellow exudate, remove some of the hypertrophic granulation tissue, and really look at the base of the ulcer. So in this picture that I've included here, this picture doesn't look too bad, but part of the exam needs to be to kind of cut away this macerated edge, because there's going to be a little undermining right here, and so you trim that back, and also this kind of needs to be scraped, and then the base of the wound here, the curette needs to go into the base and kind of pull this blackish tannish tissue out, and once that is done, the ulcer can then be described. During this part of the examination, a lot of times you'll find, tracking. It might track up to here. Might be a big old plug of dead tissue right here. This right here might track down to the bone. And so what looks like an ulcer that looks okay, once you start debriding it and examining it, you'll find that it's actually much, much worse. A lot of times these wounds will have this thick layer of yellow or tan exudate across the top, and you'll walk up to it and think it looks almost healed. But when that stuff starts peeling out, underneath that exudate, you'll find a big cavernous wound with dead tendon in the base. And so part of the exam is to use the curette and debride the wound and get a good exam. Then the other part of the exam is to either use the curette, your hand, a finger, a Q-tip, and try to feel for bone. And feeling for bone or feeling the Q-tip go into the joint, obviously that means something is much worse deep down than you initially thought. Next is the arterial evaluation. And again, a bedside arterial evaluation should be part of the initial history and physical exam. Pulse palpation is important, as is the handheld Doppler exam. What you're trying to do there is document pulses present or absent, and faint or loud, and whether they're monophasic, triphasic, or biphasic pulses. And to calculate a bedside ABI is fairly easy and quick. You just calculate the Doppler pressure in the limb, put the cuff around the leg, put the Doppler on the artery, blow up the cuff. The pressure the sound goes away, and then compare that to the pressure in the arm, and then calculate an ABI. And what you're trying to do with this is we're trying to get people to answer the question at the bedside: is there adequate flow for healing at this point. And so if you've got palpable pulses, you've got triphasic pulses by Doppler, and you've got an ABI of 1 at the bedside, you can stop. No additional vascular workup is needed at that point. But if you can't feel pulses, and you can hear kind of a monophasic, that sound with the Doppler, and it vanishes with the application of the blood pressure cuff, and your ABI is less than 0.6. Well, that's a patient that clearly has vascular disease and needs non-invasive vascular studies and a vascular consult early and quickly. And that point on the decision tree can be reached at the initial evaluation of the patient, not down the road. So this is the way the whole workflow is supposed to work, in that a patient actually comes into the hospital. There's a kind of a history, physical assessment plan. The template is designed to supplement and drive that whole flow from beginning to end. The L.E.A.P box is designed to help the physician kind of with the initial steps. These definitions are designed to kind of standardize how the assessment is done, and then there are order sets that are designed to supplement or complement the development of the plan. And the idea being that someone that does this once or twice a year or infrequently can walk in, follow the template, and find themselves providing standard of care in spite of themselves, and designed to be fairly easy and user-friendly. We set ours up in EPIC. EPIC is our EHR, and EPIC uses these smart phrases. And so we wrote these smart phrases to serve as our history and physical kind of template. You can see it kind of goes through patient is how old they are, where the ulcer is, how long it's been there, a little bit of the background as far as their diabetes is concerned, how long they've been diabetic, what their last hemoglobin A1C measurement is. And so again, that serves both as an informational prompt, meaning it should be in there. Plus, it also prompts the physician to go see, has there been a hemoglobin A1C ordered in the past year? If there hasn't, to order it. If it has been ordered, to review it. So it's both informational, and it prompts the physician to get a piece of data which you might forget about. And here's the physical exam portion, and it's a description of the wound, where the wound is, and then it's a description of the wound ischemia and infection. Again, relying on those definitions and relying on those findings from the exam before to kind of fill in the boxes. And these are all just drop-down boxes with 2 or 3 choices. You just kind of put the information in there. And then I included the definitions in the smart phrase just as a reminder. And then the idea being that once those have been read, you then just delete them out of your template. They're there, but then you just erase them. There's a place there for imaging, and then there's a plan. And again, it's divided up into that same lab work, imaging, vascular, antibiotics, kind of general care, and all those are drop-down options of fairly standard algorithmic choices. So as an example, I included the diabetic foot vascular plan. But you can see where the hemoglobin A1C is there. It says a plain X-ray of the foot will be ordered. And then for right here, there's either going to be adequate perfusion, questionable perfusion, or obviously inadequate perfusion. And adequate perfusion means you stop. Questionable perfusion means that you order the non-invasive arterial studies in order to complete that evaluation. And obviously ischemic, an obviously ischemic limb, the choice is to consult a vascular surgeon. We intentionally left off MRA and CTA and angiogram, and really the only choice we included is the kind of the formal non-invasive arterial studies, that being the arterial Doppler, segmental pressure, waveform analysis, done by the radiologist, because we really wanted the ordering of the invasive studies to be done at the discretion of the consulting physician. So if a vascular surgeon sees the patient and wants an angiogram, they can then order an angiogram or do an angiogram. And if I've already ordered a CTA, they may not even look at it. They may go straight to an angiogram. That'd be a wasted test. But if the vascular surgeon decides he wants a CTA, he can then order a CTA, and that way the test won't be wasted. So we really wanted those more invasive tests to be done at the discretion of the specialist. The order set here is designed to kind of mirror and match the plan, and these are the antibiotic choices that were decided on at the committee level. Again, it's vancomycin with options for penallergic patients. We've expanded that a little more since this was done to make it a little more robust and try to cover more kind of clinical scenarios, pen allergy being the big one. And then we included some lab work, culture data, and then again we limited a lot of the more expensive or invasive tests from the order set, because we wanted those to be ordered at the discretion of the specialist. So MRI is not on the list. Just a plain foot x-ray, which is recommended as part of routine evaluation, is included. But an MRI really should be done at the discretion of a surgeon who's going to do a debridement. So if the surgeon is going to take the patient to the OR that day for a debridement and amputation, an MRI is not helpful. It doesn't add anything. And so again, the thought being to limit some of these tests, similar to the way we're trying to limit angiograms. So that was our process. Kind of a literature library, best practice, convert those into an order set and a H&P template, and then kind of put it out there. So then the question is anyone else doing this? The answer to that is yes. It's being done in a lot of places. This approach is in the IDSA guidelines, and I included it here. I'm not going to read it, but it pretty much supports this kind of an approach, an evidence-based, multidisciplinary team providing care to these patients. There are other guidelines. There's multiple publications outlining their institutional endorsement and their experience providing care this way. But then, does it actually work? This is something I found. I think it was off Medscape, in which this podiatrist arrived at Denver Health Medical Center in 2004, and at that time there was no multidisciplinary team providing diabetic foot care, and she kind of created a multidisciplinary team with scheduled foot exams, vascular evaluations, footwear, wound care, and a transition of surgery from orthopedics and general surgery to podiatrist. In 2008, adding infectious disease and endovascular techniques. And what she found in their experience was the amputation rate dropped from 36% over the 5 years listed there to 11% from 2006 to 2011. And this was done in a really tough patient population. They had a 60% uninsured rate, they had a 35% substance abuse rate, very high coronary artery disease, very high tobacco abuse, and the hemoglobin A1C hours around 9. And she found that across the board, their amputation rate dropped irrelevant of the patient's comorbidities. So even in these really tough patient populations, by applying algorithmic care across the board using a team approach, that you can really improve people's outcomes. She presented this at the 2014 American Diabetes Association scientific sessions, and there's the reference. I think you can. I found it on the internet. There are other reports of success, both here and around the world. This is one from Germany, in which over 15 years they found that their amputation rate went down by 37%. They did it by creating a central multidisciplinary ward, in which all the patients went to one place, and in that one place were seen by a team of physicians. They also created an outpatient network of primary care physicians who could then feed into, in an educated manner, into the central team. And they also had contracts with shoemakers to try to improve their offloading of diabetic foot ulcers. In 2008, here was an article that I found out of the UK in which they reduced their amputation rate by 67%, and they credited a lot of the same factors. The other thing that they mentioned was the prospective audit. And so what they found is that when physicians realize they're being audited, they do better. And so they found that physicians do the right thing more often when they know they're being watched. And so by having this audit, they were able to improve their amputation rate. And again, there's another one out of, I guess that was out of Israel, in which their amputation rate fell, and they had weekly conferences. So when you get physicians from different specialties in the same room to talk about patient care in a collegial manner, or sometimes not so collegial, even in those situations, everybody does better and the patients do better. So they did it through a conference, and they did it through creation of evidence-based guidelines that were then adhered to in that conference, and they also had a common ward. So a lot of times just developing guidelines and then getting together and talking about them and then applying those guidelines in a group manner improves your outcomes. We've done this at Princeton with breast cancer. We all come together. The breast cancer team comes together, radiation, medical oncologists, and imaging. We talk about breast cancer and then apply evidence-based guidelines to these cancer patients and talk about it, and the patients do better. So at our institution, this has been out for about 6-7 months now, and it appears that a lot of people are using the order set a few times, and we're able to run these reports where we list all the physicians and how many times they've used the order set, and you can see people have used it 1 time, 2 times, 4 or 5 times. I think I'm on there for 6 times. We've had the most success with the residents, obviously, because they work with me, and I see a lot of the patients with diabetic foot ulcers, and then they get educated on how to use the template and how to use the order set. So they're using it pretty regularly. The hospitalists use it hit and miss, and then primary care physicians, kind of from outside, kind of that core group, use it very rarely. And the kind of the initial excitement about it has kind of dropped off. And so I think that our use of it has been pretty spotty, I guess you'd say, so far. So what are some barriers to implementation? Certainly the biggest barrier is probably physician buy-in, and there's multiple reasons for this. One is really just physician stubbornness, and I think you'll all know what I'm talking about. It takes a long time for new ideas to kind of filter through the medical community. And this is true, as you know, anecdotally, and there has been evidence to support this, that adherence to evidence-based guidelines filters through the medical community very, very slowly. And it's actually very difficult for physicians to change the way they're doing things if they've been doing things one way for a long time. But it's not just physician resistance. It's also what I've termed, this may be a real term, but it's kind of the tyranny of the everyday, the tyranny of the immediate concern, meaning that we're all so busy trying to just get through the day, trying to put out the fires of that day and just get home, that it's really hard to step back and reflect on a bigger picture. Again, that's why coming to these kind of conferences is so important, because it gives us a chance to do that. I think about a parent staying at home with little kids, and if you're trying to change diapers and keep the kids from jumping off the stairs, it's very hard to kind of pull yourself out of that and kind of reflect on your role as a parent from a big picture standpoint. And so it's just another example of how physician buy-in can be so difficult to obtain. Obviously, there are some technical issues as far as barriers. You have to have a good EHR. You got to have the ability to write the templates, have them be accessible, have an order set that is useful in the system, an order set that is user friendly and actually makes your life easier. There can be educational issues. Some physicians that don't care for diabetic foot infection patients very often may not even understand what I'm talking about when I'm talking about debridement and ABI, and so there may be some educational issues that have to be overcome just through kind of forums and however else you can do that. Then you need to have administrative support. The system has to be behind it. So as far as our institution, what is next? We really need further standardization of our definitions. We don't have a good idea of how to describe extent of tissue loss. There are some good systems out there, but we just haven't investigated them and used them. And standardized definitions of peripheral arterial disease also exist, but we haven't really put those into place yet. We've looked at just infection up to this point. We have not yet reported any results. We do not know if doing this has improved our amputation rate or not. We're planning on looking at that this December. So this year we're going to identify a group of patients, look at their amputation rate, readmission rate, all those things that I listed, these outcome measures we've identified. And then we're going to try to compare that to a group from last year or 2 or 3 years ago and try to see if we can document any kind of improvement at all. We may have made a difference, we may not have. We have yet to see. And currently our approach only looks at inpatients. We really need to develop outpatient algorithms to complement our inpatient processes, and we need to include in that outpatient vascular exams, the use of casting, the use of biologic dressings like apigraph, the use of HBO. All those things should be systematically, according to an algorithm, put into our care of these patients. And then we need to engage, educate community physicians, physicians that are out there in their office, just to let them know that we exist. This is what we're doing. This is how you get in touch with us. And obviously there is some data that says that a late referral is associated with a higher amputation rate than an early referral. So early identification, early intervention, with the goal being, intervention and foot salvage. So in conclusion, the care of these patients with diabetic foot ulcers and infections should be provided by a multidisciplinary team. We need standardized definitions and treatment algorithms that should be available at an institutional level. Bedside practitioners should be equipped with the necessary education, resources, equipment to help these patients. And you have to track outcomes and make the changes over time as needed, kind of steer the whole ship according to an objective evaluation of how you're doing. And really every institution needs a champion. Every place needs somebody, someone to step up and pull everyone together to care for these very challenging patients, with the goal being to impart to these patients, an improved life and a longer life. And that's really it. It's a very broad topic. I'd love to talk to you about it. So if you have any questions, feel free to ask me.
Let's give Dr. Bearden a hand. It's a lot of hard work, and we'll take some questions. One of the things I'll start off with is, Greg, if you could go into some details about how the EPIC EHR has helped with the implementation of the plan and standardization of order sets and so forth.
Yeah, we really couldn't do it without EPIC. If you can imagine a paper-based chart, and so you'd have your history template would be on the wall somewhere, and it'd be a piece of paper on the wall, and your order set would be you walk over and pull the order set out of a folder and put it on the chart and check the boxes. But then that requires the physician to look at the chart, and then it requires then when there are changes to be made, you got to go change all the charts in the hospital. So you got to walk around, take the chart down, put a new chart up, and that just doesn't work. The same thing being that when you have an order set change, you then have to go and pull all the old ones out and shred them, and then make new ones and put them back in and make sure all the order sets across the system have all been changed. It doesn't work, and so you can't do it without an EHR. And secondly, is that you can put prompts in the EHR so that when a patient puts on their problem list, diabetic foot ulcer with infection, the software then prompts you to use the template and use the order set, and then you then pull it up and use it. But obviously there you get prompt fatigue. So if you get 20 alerts and you got to go through them, and then one of the alerts says to use the order set. Well, by the time you've gone through the allergies and you've gone through everything else, then you have prompt fatigue, and you click cancel and keep going. So even in EHR, it's not perfect, but in EHR, it can't be done. I think it can't be done without it.
We have some questions. How many of you use the EHR? Your hospitals have a EHR Epic or Cerner or something like that? And you all used to standardized order sets now? And when you go to click something, you get your standard sets. And have any of you developed any order sets for any particular issues? Paul, what have you developed? Very good. And how about on the ambulatory side? What are you doing with diabetic foot wounds? Any of our primary care docs? Do you try to take care of them in your office? Do you send them to a wound care center? Do you do the debridement? Do you send them to your general surgeon, plastic surgeon? Back here?
We have a HBO at the hospital. We send them to the wound clinic affiliated with them. They use the HBO appropriately.
An HBO unit? How many of you have HBO or wound care centers at your facility? How many of those are non-academic facilities? Yeah, getting not a college. Okay, yeah, I guess that's good. Not a university or college. Okay.
We really thought two ways to think about this. One way was to try to get everyone to send all the consults to me or somebody like me with an interest in wound care, and that way it all becomes very focused on one person providing the care. But we kind of took the other approach of trying to educate and empower kind of everybody to provide this care if you follow the template in the order set. Because so many people touch patients with diabetic foot infections and ulcers that we tried to kind of empower everyone across the board to participate, as opposed to just trying to drive all the business to me. That's two different ways to look at it, and we took the first one. Obviously, in those papers that I've quoted, other people have done it by trying to make a closed inpatient ward. You can do it that way too.
How many of you have tried to develop an order set on your own? Paul, I know you have, but Greg, maybe go through a little bit of that. That's not an easy thing to do when you're trying to put a set of standardized orders into a medical staff, or especially across, like for us, a multi-hospital system, to get everybody to agree to a set of orders. Jeez.
Yeah, we tried to keep the order set as simple as possible and to make the order set exist as a supplement to a standardized admission order set. So on an admission order set, you're going to have your admission, diagnosis, diet, IV fluids, medicines, home medicines, that whole long list of things that you do when you admit a patient. So we didn't want to duplicate all that on this order set. So we made the diabetic foot order set to be specific to only things that you have to think about if you're admitting a patient with a diabetic foot infection. So a physician admitting a patient, presumably what we want them to do is to use this standardized history and physical, and then use a standardized admission medical order set, and then use this as a supplementary order set, to use two order sets. Use this as a supplement to the main order set. And then when they're combined, you get one kind of complete set of orders. And so we kept it very specific to things, imaging, vascular, antibiotics, things only for diabetic foot infection specifically. And there wasn't a ton of debate really at the committee level. Once you have the foundational documents, once you have the evidence, and you're all looking at the same paper, it's actually pretty easy to convert that into an order set. And any times there's a discrepancy and the order set or the data doesn't give you much guidance, you just you pick one, and everybody just agrees. We pick it, and then we'll look at it later.
And we were able to do that through the Baptist Physician Alliance, which is our integrated care organization. And Greg made some very detailed and incredibly precise presentations to the group in order to be able to get this passed through. And it's that organization that puts their, I guess, their stamp on these standardized order sets for us. Well, let's thank Greg again. We appreciate you being here.